Good afternoon, everybody. We will now be starting the EEG workshop. Am I audible?
Yeah.
So we are very lucky to have Professor Shankar Saha with us, who would be conducting this workshop. Dr. Shankar Saha is an ex-professor and HOD Neurology, NRS and RG Paul Medical College. He is also been the ex-HOD Bankura Medical College, ex-faculty BIN, ex-professor INK, and he has been the thesis guide of about 11 DM students and is an examiner for DM and DNB neurology in both Kolkata, Delhi, PGI, Chandigarh, Bangalore, and Guwahati. He has a total of around 55 publications in national and international journals, and he has contributed book chapters and is also a much sought after speaker. So may I request Sir to kindly start the workshop.
Good afternoon. Am I visible and
yes,
audible?
Both, sir. Yes.
Okay. So I want to share my slides today. I'll be talking on EEG, though the subject is EEG and neuroanesthesiology, but without epilepsy, EEG is not complete. So I have decided to talk on epilepsy and as well as neuroanesthesiology. And I have divided my talk into 3 parts. In the first part, I'll be talking on basics of the EEG. Next, I will talk on epilepsy and EEG. And finally, I will talk on EEG in other subjects in which the anesthesia is involved. Now I'll share my slide. Can you see my slides?
Yes, sir.
Okay. This EEG was first described in 1924 by Hans Barger. That is almost 100 years has been passed following first description of EEG. What is actually EEG is? EEG, there is electrical activity in the brain, as we see also in the heart. In the brain, this electrical activity causes voltage fluctuations due to electrical activity, and this voltage fluctuation can be picked up by the electrodes, which is distributed over the different part of the skull in a specific area. Now, this EEG actually, they pick up the dendritic potential because the dendrites are towards the surface of the brain, whereas the axons and the nerve cells are deep inside the brain. So what we get is the dendritic potential, but these potentials are very low. So if we have to pick up by our electrodes, we have to make some amplification, at least million times amplification is needed to pick up these waves. And as the electrodes are on the surface of the skull, so deep parts of the brain cannot be sampled very properly. See, the atypical EEG looks like this. This is the occipital area, this is the temporal area, and front is the frontal area. And before starting EEG, you have to know what are the types of waves we get in EEG. In EEG, we get alpha waves, theta waves, beta waves, and delta waves. Alpha wave, see these are these prominent lines. In between 2 prominent lines is 1 second. So you count how many waves in 1 second. As if you count here, you will see that approximately 10 waves are per second. So this 10 waves, 8 to 13, if it is 8 to 13, we call it alpha waves. If it is 4 to 7, we call it theta waves. If it is below 4, we call it delta waves. And if it is above 12, or above 13, we call it beta waves. So in occipital area, you get alpha waves. In temporal area, you get theta waves. In frontal area, you get either beta waves or you can't count the waves. So it may be indeterminate waves. Now, what are the types of EEG? That there are analog and digital EEG. In our early days, we were habituated to the analog EEG. In those days, the EEG was traced by a ink device. The pen used to write on a paper. Those papers are very large, and there are about 18 to 20 channels. So 18 to 20 ink pot through which the pens used to write on the paper. But nowadays, this analog EEG has been replaced by the digital EEG. Digital is by the computerist analyzed, and even we can do the electrical mapping with this digital EEG. And also we can do the long-term monitoring with this digital EEG. Now, in routine EEG technique, we generally go for EEG for 20 minutes. If specifically asked for prolonged EEG, then we go for 30, 40, 50 minutes like that. And in this EEG, we follow the 10-20 system. What is 10-20 system? I'll be telling soon. And there are montages, referential, bipolar, changeable digital recording. What is montage? That also I'll be explaining. Now see here, this is 10-20 system means if you join a line from in between the two earlobe, this is left side is by odd number, right side by even number. Left earlobe is A1, right earlobe is A2. If an imaginary line is there in between A1 and A2, that is horizontal line. And the imaginary line between Nazian, this is Nazian and this is Inian. This is vertical line. So the crossing of this horizontal and vertical line is a central part. And central part is suffixed by Z and right side by the even number, left side by the odd number. So there is in central part is CZ and 20% to the right is C4. Another 20% is T4, temporal. And then 10% is A2. Similarly, in the front, 20% FZ, another 20% FPZ, then 10% is the Nazian. Similarly, in the back, PZ, O2, 20, 20, then 10. That's why it is known as 10-20 system. Now, what is montage? Montage is how you connect the EEG, this are different EEG from different positions. If you connect longitudinally, like this, longitudinally, from FP to say O2, from F8 to T8, then it is called the vertical montage. And if you connect horizontally, it is called horizontal montage. Now, EEG, this 10-20 system has been established in 1958, and we use 21 electrodes. And with this system, you can have spatial resolution, as well as we can pick up the waves from the specific area of the brain. Now, even if we want to pick up the waves more precisely, then we can go for 10-10 system. You say 10%, 10%, 10% like that, 10-10 system of EEG. Now, I already told that what is longitudinal montage. You connect this electrodes longitudinally. This is transverse montage. You connect the lines transversely. Now, referential montage. What happens? This A1, the area of the brain underlying these electrodes are actually electrically active. They generate some amount of voltages or electrical potentials. But in earlobe, that is electrically inactive. So when we connect these lines among the electrically active electrodes, it is called bipolar. But when you connect the one electrical active with the inactive one, A1 or A2, we call it referential montage. So in referential montage, all are connected either with the right ear or the left ear. So that is unipolar or referential montage. Now we have to do the activation procedure if we have to pick up the actually abnormality in the EEG. What is the activation procedure we can go for? We can go for eye opening and closure. We can go for hyperventilation, ask the patient to hyperventilate for 3 minutes. Then intermittent photic stimulation, just above the eye, there is a machine called stroboscope. Through that stroboscope, we can give stimulation, photic stimulation at that is flickering light. It may be at 1 hertz per 1 per second or 5 per second or 10. Gradually, you increase the frequency so that the abnormality can be picked up. Then, and this stimulation can be done in eye open position, eye closed position. Next, the other thing we can do for activation, we can ask the patient not to sleep at night, come in the morning and do the EEG, that is sleep deprivation. We can give some medicines to the patient so that he goes to the sleep, and this is particularly applicable to the children. And besides that, there are specific method of seizure precipitation like video games, then visual patterns, checkerboard visual pattern, or we can use the anti-epileptic drugs. And then, now what are the strength and advantage of EEG? EEG, it's a measure of brain function. It supplements the neuroimaging and provides direct rather than indirect evidence of epileptic abnormality. And it may be the only test that shows abnormality in epileptic patients. And special means we can localize precisely in particular which area of the brain has been involved. It's temporal, it's frontal, like that. It is very low cost. Morbidity is also low, and it's readily repeatable, and it is available everywhere, and it is a portable. There are portable EEG machine also. Now, what are the limitation and disadvantage of EEG? In EEG, we can say that yes, there is some dysfunction, but we can't say that what is the etiology of that dysfunction. And its sensitivity and specificity is also low. And there are many artifacts that may come from the sweat, that can come from eye movement, that can come from muscle. So that may be confused with the cerebral activity. And it also, if the patient is very alert, if the patient is hypoglycemic, or the patient is on some drugs, the EEG may change. And very deep lessons cannot be picked up by the EEG, and time also very limited to do the EEG for 20 to 30 minutes, and it may even falsely localize epileptogenic zone. Now, why the EEG is used in seizure disorder? How does it help? It helps in clinical diagnosis of epilepsy. It can classify seizures. Also, it localizes the epileptogenic focus. I will show in the graph how it looks like if there is a focus. It also quantifies the seizures, and we take decision after doing while treating the epilepsy patient. If the patient is attack-free for 3 years, then we take this, go for EEG, and if EEG is absolutely normal, then and then only we decide whether to stop the medicine or not. But it is not a good guide for effectiveness of the treatment. Now, what are the things in EEG we see? Let's see the next slide. These are typical EEG. This is the alpha wave. This is the theta wave, and frontal, this is the indeterminate activity. We look for the morphology of the EEG, and we look for the duration. Suppose in this, there are 10 waves in 1 second. So there are about duration is approximately 10 milliseconds. Then we look for the amplitude, this voltage. What is the voltage of the EEG from tip, bottom to the tip? We look what is it. Suppose it is about 3 millimeter. For 1 millimeter here, it's written in the top, there are 5 microvolts. So in 3 millimeter, there is about 15 microvolt. So we look for morphology, distribution, frequency, voltage, duration, and what is the state of the patient, whether patient is sleeping or patient is awake, and background from which it is coming from. Next, now, how to interpret the EEG? Actually, one should interpret the EEG first without knowing the patient's history. If he knows already the history, then he will be biased in giving the opinion. So first interpret the EEG, then correlate it with the patient's history. Now, what is the interpretation? EEG is either normal or it is abnormal. What are the types of abnormality? Either there is a non-epileptiform pattern or there is an epileptiform pattern. What are these patterns? I will describe. Now, epileptiform pattern, it may be in between the attacks of the seizure or during the seizure. During the seizure, there are 2 types of pattern. One is isomorphic seizure pattern, one is metamorphic seizure pattern. Now, what is the criteria for epileptic transient? It should be cerebral. It should come from the brain tissue, not an artifact. How the artifact looks like, I will show in my graphs. And whether it is abnormal for the age. Suppose a delta wave, slow waves is coming in an adult in awake state, that is abnormal. But if it comes in the adult in sleep stage, it is normal. So state of the patient is very important. Now see, now I'll show you some graphs. Suppose, say this is the sharp wave, and this is benign. This is not abnormal, though this is sharp wave is not normal, but there are some graphs which are not considered to be pathological. Now, what are the activity that is not normal, but that come physiologically? that is vortex transients of light sleep. In light sleep, in the vortex position, we can get some abnormal waves. These are normally comes in particularly in children. Hypnagogic hypersymphony, that is hypersynchronous wave during sleep, that is physiological. Post positive occipital sharp, in occipital region, there are sharp wave may come, that is normal in sleep. Mu rhythm. Mu rhythm is just like alpha, 8 to 13 hertz rhythm that comes in the temporal lobe, in the central CZ position, C1 to C4 position. But the difference from the alpha is that mu rhythm does not respond to eye opening or with the alertness. What is lambda wave? Lambda wave is 1 to 100 hertz wave that come in the occipital region, and particularly it appears when the patient is reading or seeing some television. What is breech rhythm? Breech rhythm is when there is a gap, bone gap, in suppose after craniotomy, the wave coming from that area is known as breech rhythm. How it looks like, I'll show in the next slide. See, you compare this. You compare this line. You compare this line with the rest of the columns. See, there is amplitude of the wave is high and it's very irregular. There is a craniotomy in this area, so it is known as the breech rhythm. Now, what are the other benign variants? In sleep, there are some benign epileptiform transient may come. There may be 6 to 14 hertz. In some area, there is 6 hertz spike. In some area, there is 14 hertz spike. Then what is spike then? If the wave is less than 70 milliseconds and the tip is like a spear, we call it spike. If the duration of the wave is 70 to 200 milliseconds, we call it sharp wave. If it is more than 200 milliseconds, we call it slow waves. There may be wicked spikes. Wicked spikes appear in the temporal lobe, 6 to 7 hertz. Psychomotor variant, how this look like, I will show in the next slide. Phantom spike and wave, I will show. Now see, these are small spike. These are small spikes. This is psychomotor variant. You are getting these sharp waves in the frontotemporal area. This is called psychomotor variant. Psychomotor variant. Now, interdictal, already I told you what is spike, what is sharp wave. There may be other spike and wave. After the spike, a slow wave comes, that is called spike and wave. 3 hertz spike and wave. In once again, three waves will come. First spike followed by a wave, slow spike and wave, hips arrhythmia, photoparoxysmal. I'll show how this look like. Spike and sharp already I told you. Then in epilepsy, we may get generalized coming from all the channels. We may get particular partial or focal coming for a particular system, temporal or the frontal area. We can get generalized in symptomatic epilepsy, hips arrhythmia, slow spike, and partial. This I'll show, then you will understand what is this. See this, in this graph, there is a 3 hertz spike wave. See in 1, 2, 3, there are 3 waves, and each wave there is a spike followed by wave. There is a spike followed by a wave. This is called 3 hertz spike wave. It is typical of petit mal epilepsy or absence seizure. This is another example of 3 hertz spike and wave. This is polyspike. Polyspike, more than one spike. More than one spike. These patients, they generally present with sudden jerky movement, that is myoclonus. This is also polyspike and wave. There is polyspike followed by a wave. Polyspike and wave. This is hips arrhythmia. Hips arrhythmia means totally disorganized background. You get slow waves, sharp waves, interspersed with spikes. This typical EEG, known as hips arrhythmia, is generally seen in tuberous sclerosis. There is a triad called characterized by mental retardation, then adenoma sebaceum, that is tuberous in the face, and this hips arrhythmia. This is typical of tuberous sclerosis. Now, this is slow spike and wave. Slow spike and wave. Excuse me? Slow spike and wave. This, you see, this abnormality is coming particularly in this two channel. This is spike and wave. Benign Roulandic epilepsy or benign, this is benign epileptiform discharge of childhood, also known as benign Roulandic epilepsy. Now, interictal spike you can get from different lobes, temporal, frontal, occipital. And if you get a focal discharges, it helps you in localizing, and it is generally, in most of the cases, there is some structural pathology. See, in this particular case, this is coming from this left temporal area. So there must be some pathology, either maybe tumor, it may be some. This is coming from the frontal. This is coming from the posterior temporal. This is localized. Now, if you do an EEG of a normal person, so suppose you are calling a person from the street and doing EEG, there is a chance of big abnormality. Generally, in a study, they show that 2.7% to 8.7% abnormality in a normal person. So if there is abnormality in EEG, it always does not mean that patient has epilepsy. And similarly, you may get normal report in an epilepsy patient. In one study, there is 56% patient has abnormality in an epilepsy patient, rest to a normal, and subsequent record show another 26% became abnormal. In pediatric population, 25% did not show any abnormality in a non-epileptic patient. So if a non-epilepsy patient, the EEG report is normal, it does not exclude epilepsy. Now, what is the character of the generator source? If the generator source is, if the large area of the brain has been involved and there is synchronous activity from that area, then only that can be picked up by the EEG. But a small area is involved, it may miss. And also the distance between the electrode and the source. Suppose the pathology is deep in the brain and you are picking up from the surface of the scalp. So there's a much distance, so we can miss. And also orientation of the dipole. Moreover, how long we are doing the EEG. Generally, routinely, we go for 20 to 30 minutes. But if we go for prolonged EEG, we can pick up much more. And we have to do some activation procedures. What are the activation procedures? We can ask the patient to go for sleep. We can give photic stimulation. We can go for hyperventilation. And also relation of seizure. Suppose the patient had attack yesterday and today I am doing EEG, the chance of getting abnormality is more. Age of the patient. As age advances, the chance of getting abnormality becomes more and more. And also anticonvulsant withdrawal. Now, recording of focal interictal space. This, if we record in sleep, in the third stage of NREM sleep, stage 3, the chance of getting abnormality is more. If we deprive the patient from sleep, chance of getting abnormality more after seizure and during long-term monitoring. And sometimes we need some depth electrode, like sphenoid electrode, nasopharyngeal electrode. These are sometimes needed. And this focal interictal space is not affected by anti-epileptic doses and hyperventilation or photic stimulation. Now, what are the epileptiform pattern we get? We get interictal epileptiform pattern and electrographic seizure pattern. And electrographic, isomorphic, and metamorphic seizure pattern. What is interictal electrographic seizure pattern? Electrographic seizure is, there is rhythmic component. They may not be spike, may not be sharp wave, but the waves are very rhythmic and they may not have any epileptiform activity and they last for several seconds. And when this produces clinical symptom, we call it seizure pattern. When it does not produce symptom, we call it subclinical seizure. Now, isomorphic seizure pattern means it, as it appears, the beginning and the end is same. There is not much change. And this is typically, you just remember those triad, spike and wave, absent seizure. It comes suddenly and disappears suddenly. Following the attack, there is absolutely normal, no change in the background. But in metamorphic seizure pattern, following the attack, there is some change. There's some slow wave may come, then again spike, and so on and so forth. So metamorphic seizure pattern is not finished with different type of wave patterns. See, in this EEG, you just concentrate here. This is the abnormality. This left temporal lobe abnormality is showing slow wave and sharp waves. See, this is generalized seizure. The abnormality is seen in all the channels. Now, if we do the EEG during the seizure, it is always abnormal in generalized seizure and also almost always abnormal in partial seizure with loss of consciousness. But if it is simple partial seizure, it may come to be a normal record. Now, long-term, when we need long-term EEG monitoring, sometimes we need long-term. In the generally, either conventional EEG is done for a long period. Generally, ambulatory, we can do the ambulatory EEG, and we can do the video recording as well as radio and cable method. Now, video EEG, when we need video EEG monitoring, if we need a prolonged EEG recording, and also if we attach it to the video, we can know the habitual seizures as well as the behavioral pattern of the patient, and we can correlate with the behavioral pattern with the abnormality in the waves.
चलो हमारा exchange offer हो गया.
Now I will show you some graphs which is needed for the anesthetic people. This is burst suppression pattern. Burst is sudden appearance and sudden disappearance. Sudden appearance of the spike sharp waves, sudden appearance of spike sharp and slow waves, and this is interspersed to a suppression pattern, straight line. This burst suppression pattern is seen in a child who is hypoxic at birth, and they presented with jerking of the whole body. This is another burst suppression pattern. In the burst, you see alpha and theta range and interspersed with some spike wave. This pattern is seen in an woman who has a ruptured ectopic pregnancy, following which she underwent she had a cardiorespiratory arrest. This is very dreadful condition, and this patient died. See this wave. This is a concentrate on this first two line. It's a triphasic wave. This is one wave. This is another down and then up. So this is three phase. This is called triphasic wave, rhythmic anterior dominant triphasic waves. This is typically seen in metabolic encephalopathy, and this patient is a case of hepatic encephalopathy. See, this is a brain tumor. It is a posterior part of the frontal lobe. And see, in frontal area, there is theta and delta activity. Theta and delta, but the rest of the EEG is normal. So if you get theta or delta, you can guess that probably a mass lesion may be underneath. Again, this is a slow wave in the frontal area, bilaterally. This type of slow wave, you get in some structural lesion, mass lesion, tumors. Also, you may get in encephalopathy, this type of slow waves. This here say suppression of the waves. This alpha suppression you get in head injury. If the patient has cerebral concussion, then you can get suppression of the alpha activity, very low voltage alpha activity. This patient has a head injury. And gradually he recovered, and the alpha waves returned after recovering. See, this is a stroke. This patient had a MCA territory stroke, and the background you see, the alpha is replaced by theta and delta waves, no alpha in this stroke patient. This patient is a locked-in syndrome. You know, in locked-in syndrome, there is a patient can only communicate with movement of the eyes. In this patient, you can see the theta and delta waves, no alpha waves. But the difference is in alpha wave, patient can, there is alerting response. If the patient opens the eyes, the alpha suppression occurs. But in locked-in syndrome, it does not occur because for alpha suppression, they need some message from the medulla and midbrain, medulla, pons, and midbrain. As it is disconnected from the medullary, pontomedullary area, so no message has been, can go to the brain, so or cerebral cortex, so that activation procedure or alertness response is not seen in locked-in syndrome. See, this is a patient of hydrocephalus. He had a shunt, and that shunt has been blocked. Due to blockage of the shunt, the intracranial tension rest. This is, you get theta and delta activity in rest intracranial tension. See, this is a low voltage EEG. Voltage is low. You can see it in chronic alcoholism. Again, a burst suppression pattern. There is a burst. There is a straight line in between. There is again a burst. This burst suppression pattern, this patient has a cardiorespiratory arrest 24 hours previously. This patient was in coma and he was attempted to arouse the patient. These are muscle artifacts. There is attempt in arousing the patient, but he has not been aroused. And you see some spindle waves. These are spindles, just like comb. These are spindles. So in comatose patient, the appearance of the spindle tells that it is a spindle coma. There is again alpha and beta waves, more than 13 hertz and more 8 to 13 hertz waves. This is a patient of coma. In coma, we expect that there must be slow wave, delta to theta range. But here you see alpha and beta range. If you see alpha and beta in a comatose patient, the prognosis is very bad. This patient ultimately expired. This is also comatose patient, but you are seeing alpha. So if you see alpha in a comatose patient, it is called alpha coma. Here also prognosis is bad. See, this patient, he is neither in coma, nor does he have any history of epilepsy, but there are some abnormal waves coming from the temporal lobe. Temporal area, spike and sharp waves are coming. This patient, we know that temporal lobe is the speech area, comprehension. This patient had speech problem, and so the abnormality is found in temporal lobe. This patient was treated with carbamazepine. Ultimately, speech recovered. Now I'll show you some EEG which is done in our own lab. This, you see, there is abnormality in particularly this area, frontotemporal area. This is a focal epilepsy. He had underlying pathology in the frontotemporal area. This is typical 3 hertz spike and wave. Already I have shown this is in our laboratory 3 hertz spike and wave. This is a case of petit mal or absent seizure. This is generalized discharge. Generalized discharge. Again, generalized discharge. See, again, focal, coming this area. If we get focal discharge in a patient, always suspect of some underlying pathology. It may be tumor, spaciocopaing lesion, or it may be stroke or something else, but the possibility of underlying structural pathology is more in case of focal lesions. This patient does not have any history of epilepsy, but he is having abnormality. Generalized discharge. He is a case of vertigo, but having abnormality. So abnormal discharges can come even without the history of epilepsy or any spaciocopaing lesion. This is again generalized discharge. What happened? Now, see in this, sorry, what happened? Is the time up? Oh, see, in this patient, you see some abnormality here. It looks like spike wave, but actually how to differentiate from the artifact? Here the patient was tightening his left lower limb. So the abnormal muscle activity is coming from the right parietal area. Here the patient was tightening his right lower limb. So this spike-like activity, this is actually muscle activity. These are muscle, these are all artifacts. I'll show you some artifacts. Here the total body patient was tightening. So whole body, you can get muscle artifact from the whole body, and it looks like spike. If you don't know the artifact, it will be interpreted as spike discharge abnormality. This is both hand he was tightening. So this side and that side, these are muscle artifact. This is patient was coughing. Patient was coughing, so muscle artifacts are coming from both sides of the body. This is an interesting EEG. The continuous low wave activity is seen throughout the tracing, continuously. This type of EEG was given in a DM final exam, and the candidate told that as it is continuous discharge, so probably patient is suffering from status epilepticus. But actually, you know what is it? Patient was continuously blinking. The cornea is negative in relation to retina. So if the patient closes the eye, the wave goes upward, and opens the eye, it goes downward. Here, due to continuous blinking of the patient, the slow wave is coming throughout the tracing. Now, before I conclude, I think my talk won't be complete if I don't say a few words about brain death and EEG. You know, brain death is a clinical diagnosis, and we say it is a permanent irreversible coma, and there is loss of all brainstem reflexes. And also we confirm by apnea test. But the thing is, the most confirmative test for brain death is cerebral angiography. But sometimes it is cumbersome, and sometimes the patient party doesn't allow to do the cerebral angiography. So in that case, EEG may help, particularly if the patient has open scalp injury, or if the patient has eye injury, one can't test brainstem reflexes. In that case, EEG helps. Now, while doing the EEG in the brain death patient, one must be cautious whether patient is under any sedative drug, whether patient has hypothermia, or whether patient has got metabolic encephalopathy. And there is a guideline for EEG in brain death patients. There's a French guideline. They say that the EEG must be done twice, 4 hours apart. And in no tracing, there should be fluctuation of the line more than 2 microvolt. It must be either a straight line, or maximum 2 microvolt may be allowed in 2 EEG 4 hours apart. This is for brain death. But the problem in EEG in brain death is the brain death patients, they are generally attached to many gadgets, like say ventilator, saline, endotracheal tube, so on and so forth. So from all these gadgets, the artifact will come, and that may be confused to abnormality in a EEG wave. So one must be cautious about that. In spite of that, EEG is a very good test for brain death patients because it is ambulatory, it is cheap, and it can be repeated, it can be taken to any places. So that in that way, EEG helps in brain death patients. Another thing I should mention before concluding, that EEG, in particularly the anesthetists, they want that during from conscious to the unconscious level, they are passing through stupors, deep semi-coma, coma, like that. They want to know, can we predict what stage the patient is now from the EEG? The conventional EEG, what we are using now, we cannot predict with that conventional EEG. But a new EEG has come. It's come from the Ireland. that with that they do some logarithmic calculation. They do pick up the waves from the frontal area, and there is some algorithm and there is logarithmic calculation, which I don't understand much. I don't know whether those type of machine is available in India or not. In that machine only, one can predict at what state of the conscious level the patient is. So with the conventional EEG, what we are using, we can say at this stage that it is a valuable tool for evaluation of the seizure disorder, and interpretation of clinical significance of EEG abnormality can only be done by the physician who is evaluating the patient's history and finding and has an understanding of the benefit and limitation of the EEG recording. Thank you.